I am a I am a pediatrician and epidemiologist by training. I started my career at CDC, and I've worked in maternal and child health with them for 22 years. Through them, I worked in three different state health departments. I worked in the Massachusetts Department of Health, the Mississippi Department of Health, the South Carolina Department of Health and Environmental Control. Then I also got a chance with CDC to be assigned actually out to City Match, and spent 4 years out there working with urban health departments. And then I went back to CDC in Atlanta and headed up their MCH EPI programs. Uh, I have found when I got near retirement from CDC that I really need a combination of both. I need to be an epidemiologist, but I also need to be doing maternal and child health. So after I retired and left there, I came to the Florida State Department of Health, and then got recruited here to the university. I'm now a professor here at the College of Public Health, director of the Child Center, and I'm also director of a perinatal quality collaborative for Florida. If you're not, I'm sure most of your states now have perinatal collaboratives, at least 42 of you do. We right now are working with about 84 hospitals across the state of 110. They account for about 80% of our births, or about 169,000 deliveries a year. We're working on efforts to reduce cesarean, to improve the quality of care for mothers and babies on opioid. We just started a family centered care initiative, and we're doing a variety of other things that be interesting to you all. We do a lot of perinatal quality monitoring and systems for hospitals now to know where their results and values are in comparison. So we do a lot of work. Our primary funder is the state health department and CDC. So I stay connected with all those other parts, and I still use our EPI tools. We just published an article on maternal mortality rate here in Florida and what's been happening to decrease it related to Quality Collaborative. And we're working on a piece right now comparing different measures of low risk cesarean and doing it in the applied world, and showing that some of the measures may not be as strong as people are advocating when you actually apply it in a practice perspective. So we're working on that piece. So I continue to do a lot of those pieces. I'm very much an open sort of person. This is our chance to talk together. If you can't tell, I love what you do. I did what you did for almost half my career. I continue to work with your counterparts in my states and other places. I think you have some of the best positions, and my hope today is that I can help you be more effective at what you do. And if I can provide any advice or guidance or assistance at any point in time, please don't hesitate to reach out. Why don't we go ahead to the presentation then? Let's see if I can make this work well. I want to thank everybody who did the exercise. I know it's a lot of work, but one, I like the exercise for a couple of reasons. One, it gives you some experience, especially with some of the tools I'm going to talk to you about. But two, it also gives you an idea of what you all are frequently asking your state partners to do to try and assess the situations. And we'll talk more about that soon. Hopefully you listened to the talk on planning and public health planning, and how I call that being effective in public health. Again, I try to remind people that if we don't plan, we really can't be effective. And the other message you're going to hear to me is epidemiologists, if we're not part of that planning process, we can't be effective. I do want to acknowledge that we all use different materials. I use materials that Mary Peoples-Sheps and Ada Farrell, Mary Rogers, and others have done. We put some of this material together when I was there actually at City Match. I borrowed from Greg Alexander and Donna Peterson. And then for the exercise, I borrowed a lot of material from the Florida Department of Health here. As you know, I talked about how planning is an integrated process. You get it presented to you like it's linear in the schools of public health, but in fact, it's not linear. It usually is, you may be at several stages at certain points of time. Um, and it's very important. And you may wonder why an epidemiologist is teaching you about planning and needs assessment. And the reason we do it, one is you have an important role in needs assessment, and you need to understand that. And two, I'm here to advocate to you that if you want to be effective in your state or community health department or your local agency, you need to be engaged in the planning process, because what you do is only useful if it contributes to planning and decision making. When we were at City Match, we created the idea of what does it take to effectively use data. And we say it takes three things, and I'm not going to talk long on this, but I just want to highlight this because needs assessment fits in. One is you have to have a knowledge base, and the work that we do in epidemiology and our review of the literature, the data we analyze, adds to our knowledge base, and it helps us better understand an issue and what to do. But we need an effective strategy to address it, and we need to have political will. We need to have leadership and people who are willing to tackle the issue. As an epidemiologist, this is critical for you to think about, because when I finished, I thought all my role was just to do the analysis and write it up and turn it over. And that it was quickly shown to be ineffective. It is about being part of a team. And so that many of the projects, in fact, almost any of the projects I work on now, includes not only the epidemiologists, but I include the people who are involved in the strategy and the political will. And we all work together so that everything is in an integrated fashion. Just to let you know that we're not off base, there's been a whole series of articles that came out about consequential epidemiology in the last decade. Bill Fahey first came up with this. He was the director of CDC and the president of APHA. And the idea is our epidemiology is not just about producing numbers and studies, but it's taking our epidemiology and helping people use it as a tool to create the change that we need to have happen. Gala, who at the time was president of SCR, went ahead and did some analysis, and he looked at 4 leading epidemiology journals, and 85% of the studies that were published in those journals were related to etiology, and only 15% had any direct implications on the lives of people. So that as an epidemiologist, we were attempting to do those things that we were trained to do and not doing those things that need to be done in an applied world. And that really directly relates to your jobs. And then he went back later and then looked at the 14 leading textbooks and found that almost all of them were focused on the majority of causation and on the distribution of disease. And if you go back to John Snow, that's not what John Snow did. John Snow was all about trying to figure out the epidemic and then removing the handle from the pump. His implications were that we need to be setting epidemiology priorities. And I'm going to talk about, in my opinion, how you need to do that. We need to shed concerns about taxonomy and identity and work on teamwork and working together. We need to be open to new methods and approaches that may not be exactly what we were taught. We need to focus on the global perspective now, because COVID certainly proves that. So did Zika. We need to raise issues that might not otherwise come up. We are to be a spokesperson on those things that are not always discussed. We need to focus on implementation, and we also need to focus on the next generation. We're here for the long run. So I just want to put that out there. And when we talk about being effective in public health, frequently people get assigned the task of doing needs assessment. And one of the things you'll hear from me is there needs to be a group who's responsible for the whole planning process. And whatever we do in assessment needs to be part of a larger planning effort and be connected to those. And we need to think about it from that perspective. In other words, how you organize yourself to do a needs assessment and how it connects to planning impacts the ability to have that really make any difference for women, children, and families. One of the things I can tell you, my biggest frustration in my career has been to spend a year or two working on some epidemiologic project and have it not be used. That that to me was a waste of my time and energy, let alone the resources that went to have me do that. So having things set up in the right context and the right way is important, and that is true with needs assessment. Um, so why does an epidemiologist fit in? Besides for us frequently knowing the data, a lot of the functions of the planning cycle relate to us as epidemiologists directly. We need to be doing a lot of the needs assessment work because we understand the data. We need help, but we need to be actively part of that assessment process. We should be playing part of that monitoring role. What are the key indicators? What are the key measures that need to be out there so that we can monitor the progress? And frequently we have to be those people helping with the monitoring. I don't know about your health department, but most of the places that I've been in and have worked with, they have one staff and they do both the epi and the evaluation. And so we need to be able to be part of that evaluation, if not doing it, being at least part of it. So that we have to play key roles, and our roles contribute to the whole plan. And in fact, I would say the activities you do need to fit into these sort of functions. There's one activity that's not really part of this that I would add. Well, two. One is I do think we have a role with capacity and strategies. Frequently, the epidemiologists are best trained to review the literature and understand the evidence base, and that we may need to help with the research behind what the options are related to planning. The last piece is we do have a role in what I call awareness. We need to bring up the issues that no one else talks about or may be aware of. For example, in Florida, when I came here to be the state epidemiologist, CDC put out a report and we found out that Florida had one of the lowest contraceptive use rates among among women who need to be on contraception in the country. And so my job got to be to explore that, to understand why, and to help speak up about that everywhere, about how we were not addressing a major issue. So I wanted to start out when we talk about planning and needs assessment, why does it matter to you all? Because it really is the essential parts where you connect. And I would argue that there's almost nothing that you do that doesn't need to fit into this process. So why is planning so important to MCH epidemiologists? Again, it provides a focus so that the data and research that you're doing and your expertise can be directed toward it. You will hear me tell you that you need to be part of your MCH team. I know many times the data people are put off in another unit or another place, and you just provide data. But if you let your structure let you play that remote role, you will miss out on making the contribution that women, children, and families need. The other thing is you need to have common priorities. When I was at Florida and my other places, my directors would always say, well, Bill, what is your unit's plan for the next year? And my response would be, what are the priorities of the division or bureau? And that needs to be my priority, and my planning needs to relate to it. So once you turn your priorities in, then I can talk to you about what the priorities that we have so that we're working on the same things. It provides a common language and framework. I mean, part of the biggest problems working in team is making sure we understand each other and that we communicate well. And being part of that process has everybody understanding how things work and communicating in the same way. I will tell you, it leads to data-driven and decision-making, because decisions are made through plans. And if you're not at the table with the data that's needed, then you cannot guide and steer those plans. And that leads to the translation and action. So I would say it's almost essentially be part of the planning process if you're an epidemiologist in a public health agency. Before we get in detail in needs assessment, any questions about public health planning, epidemiologists being engaged? Why is it important to you and what the work that you do? Does this resonate? They tell me I need to put my slides down so that you all have the opportunity to speak.
Can you hear me okay?
Yes.
Oh, I was just going to say that capacity, I like how you highlighted that one because sometimes I'm from Wyoming and we're smaller and we have program managers that think of all kinds of different data, and we do have 2 MCHFEs, which is really nice, but I'm also mostly PRAMs. But capacity, we have to remind them that if they have a grant that they could source out, that we may not have the capacity to do everything that they want to do. So I definitely, that resonates with me largely.
That's very good. But I would also encourage you when they contract it out that they try to keep you at least engaged enough to know what's happening and what they're doing for you so that you can have
Yeah,
a
we're
handle.
always a part of that process, and we have
Good.
team meetings with whoever they contract out with, so we can make
Good.
sure we're getting the right data to use. So, yeah.
Others? I say that because when in person, I would actually walk up and talk to you, and I can't do that today. But usually I'd say almost half of you, and it varied from year to year, were in positions where you mainly were sort of given assignments of what to do related to data, and that you had a lot of distance between what you get in terms of data and what the programs are doing. And I would encourage you to collapse that distance. That most places, if you were to try to engage in some fashion, they would be happy to do that. You just need to build that into the way you work and the way you communicate. And if you're interested in talking about that, I can spend more time on that. Other questions, feedback?
A handful in the chat did say it absolutely resonates with their work as well.
Thank you. Actually, please do keep on top of that. I don't know that I can.
I can certainly do that.
All right. All right. So let's talk about needs assessment. And the way I try to do it is to better understand our problem. It's a health, and again, I'm going to talk mainly today about part 1, which is health problem identification prioritization, but I will also highlight part 2, because in fact, part 2 is probably the most valuable. So what is your all's experience with needs assessment? Well, 2 of you, I would love you to help me give this lecture because you're advanced at needs assessment. And hopefully you can provide key insights, but there's 14 of you who have intermediate basis. Most of you are at the basic level, and some of you have no experience. So again, this is a chance to ask questions. If you disagree with me, that's great. If you have other options or alternative or approaches, let me know. I'd love this to be a discussion. Now, we did not ask it this year in the assessment, but in the assessment last year, it was interesting to know what type of needs assessment people had experience with. And of those who had experience, 71% of them were on Title V needs assessments. Part of that was because they were just recently due a couple of years ago. Title V family planning programs, home visiting programs, and state health improvement plans. So it is something that you continue to encounter. But again, as you think of needs assessment, you need to think about needs assessment as one step in a whole process, and it needs to be built into that whole process. And the reason I bring it up, as I mentioned in my earlier video talk, many people assign assessment out to one unit, capacity and strategy and planning to another group. A different group will do the budgets. And no one gets around to doing evaluation. So everybody has evaluation questions that they put in their needs assessment because they didn't do their evaluations. And so it's a dysfunctional process in many places, and it needs to be tied together. And you can do your part if you're involved in the needs assessment. So in terms of a definition of needs assessment, I see it as a systematic collection and examination of information to assess and prioritize the needs, to make decisions, to formulate a plan leading to public health action. And those components are very important. One, you need to assess and help prioritize the needs, but the information you get needs to feed into what can be an action plan. I can tell you how many people have done needs assessment and put out great data books to highlight the needs assessment they've done, and it shows no connection to priorities and what's planning needing to be done next. And so that's a data book and not really a needs assessment as part of a planning process. Your assessment should help lead to the next steps. And those steps should be public health actions. Needs assessments need to be systematic. The key is to be is you want to make sure you hear from everybody and that all perspectives are there, and it's done in a way to be there, and it's to be inclusive. These assessments is an opportunity where everyone should have a voice, including disenfranchised and vulnerable populations. And you need to make sure your process gives the opportunity for that inclusiveness, because you may not, as a group, prioritize an issue, but this is your time to assess whether you should or should not be. It does need to be visionary. I say that because many people's needs assessment issues and questions all relate to evaluations, which should already be done. The idea of the needs assessment is, what do we need to be focusing on going forward? It needs to be conceptual. You need to have a framework that really takes the science and evidence and input and put it into the decision so that it's not arbitrary. The last three are really critical. One, it needs to be pragmatic. For example, I do remember one year we were in the health department and we had a budget cut. And essentially we were not going to be able to take on a lot of new initiatives and new projects. So we tailored our assessment to fit in that constrained framework. There's no reason to spend a lot of time on a broad assessment to be inclusive of lots of new topics if in fact at this time you do not have the bandwidth to do that. It needs to be very pragmatic in the sense that now in one of the agencies I was at, the decision finally reached the point that the secretary or agency lead needed to decide finally what the priorities would be. And that our job all the way up was to make our recommendations, but they had to be approved at the highest level. So we need to make sure our decision-making process was clear to everybody and how those steps would be, and that the process was clear but pragmatic. Your needs assessment needs to be action-oriented. It does not need to lead to a pile of data. It needs to lead to priority and clear focus areas and things of next step. And lastly, your needs assessment process needs to be cohesive. By that, by the time you get to the end, what you're trying to do is bring all your partners together to work collectively to improve the health of women, children, and family. So you need to make sure your process is such that you're including all the people who need to be involved in that, and that you've done it in a way that they are going to be engaged in action with you. There is nothing worse than to do your needs assessment over in the corner and then just tell everybody what it is and why you will now not come join us and work on this. In other words, it needs to be a process that brings everyone together. That's why that planning process overall gets to be important. Now, there are a variety of needs assessment. There are a variety of different methods. I'm going to try and present it fairly simple. A lot of what I do is what's frequently done with Title V, but a lot of the principles actually relate to the different types of assessments that you may do and the different methods you may use. One, I mean, many of you work on state health improvement plans now. Some of you work on Title V, but you can do a needs assessment, which is a population or a community, but you can do it on a health system. If you're working with EMS or some sort of emergency response, that's going to be a system. If you're working with a program like Title V or a home visiting program or WIC, it's going to be more of a program type of assessment and defined by program and what's there. You may also do a needs assessment related to an identified health problem and what do you need to be doing to address that health problem. But a lot of the steps are going to be the same no matter what the focus area is. I generally try to think of needs assessment, breaking it down into two components. There's a part one and a part two. And the reason I do that is most people in their needs assessment do part one and they never get to part two. In fact, I would say they spend 90% of their resources on part one, but your impact, your ability to make a difference in the lives of women, children, and family is really going to be based off of part two. Part one, you want to identify health problems and you want to measure them. And then based off of that description, you want to prioritize them. But knowing your priorities is not going to help you address those problems in an evidence-based fashion. You need to take the next step in your needs assessment and do a problem analysis and really understand well what are the contexts and the drivers to the problems that you prioritize, so that that can fit in with potential strategies that can be used in the capacity that you have to use it. But what I like to say is we have more priorities facing women, children, and families here in the United States than we have resources between staff and money. And so we need to sort of choose those that we want to focus in on, given our context, our situation, and resources, where we think we can make a measurable difference. But once we choose those, and they can vary, and they have for me over time, the biggest piece is how well can we address those priorities? Because we cannot have an impact if we have not understood the issues we're addressing. And many times people try what I call cookie up application. If I have this problem, I'll just do these strategies. And your strategies need more information to align well. So to start out with, so if we're going to identify health problems in that phase one, what is a health problem? What makes something a health problem? Does anyone want to tell us what you think defines something to be a health problem? You're going to start prioritizing all your priorities so that you can do a needs assessment and select what you're going to work on. You got to decide what the unit of work is. So what makes something a health problem? When I'm on this, presentation mode, actually, I can't see comments. Are we getting any comments?
Not yet, and you're welcome to unmute as well. So feel free to unmute or utilize the chat.
So for me, the health problem is whatever is having some certain mortality, or if there is any reduction in the productivity of individuals in an area or in a certain population, that I can define that as health problem.
Very good. And I want to say you started where I was. You must be trained as an epidemiologist. The first thing that we focus in on as a health problem epidemiologist is an outcome. And we see our health problems being outcomes because that's how we're trained. We're trying to improve outcomes. However, when we go to the community, We in the past, we went to community group to work on chronic diseases, and we told them we wanted to work on chronic diseases. And you know what the community identified as their health problem? Unsafe neighborhoods. So our funding wanted us to work on chronic diseases, and unsafe neighborhoods are not necessarily an outcome. So I will tell you, when you start doing your needs assessment and you listen to your various stakeholders, you need to think about what is your definition of a health problem. And I would encourage you to broaden your definition. I say that because, again, your whole purpose is to lead to action that's going to improve the health of women and children and families. And you're going to need to do that in collaboration with others. So that you need to define your health problems based off of what your stakeholders and you perceive. So as with that safe neighborhoods, that health problem could be community perception, could be an outcome. But for example, in public health, we frequently talk about smoking being a health issue, but it's really a risk factor and it's not really an outcome. So we do make some of our risk factors, like in obesity, we'll make that a priority. But we will also take some of our service things and make that a priority. We talk about vaccination rates. We talk about entry into prenatal care. So those really are an outcome. So we'll talk about those. So we may talk our risk factor. We may talk about a health service issue. We might try to find it by measurement. A lot of people like to do it by comparison. For example, well, something's not a health problem unless we're worse than the US. Of course, I've lived in states where they would never use the US as their level or standard because they're far better than that. So when you get to your health problems, one of the first things you need to do with your stakeholder is define what is your unit of a health problem.
And Bill, I'm gonna stop you here and read a few of the other examples shared in the chat.
Please do.
One example from Kauai in Hawaii, we're on a grant and we typically use our previous year's benchmark performance measures to identify problems. Benchmarks that we don't do well on get identified as issues for the upcoming year. Nicole shared a physical or psychological state of being that we think should be better than it is.
Good.
Paulette shared anything that negatively impacts health. Often it's a social determinant of health. Neva, when a number for your state is largely different from the US, or if there is something that is identified by our focus groups, by our stakeholders, or through our PRAM surveys. And Florence shared affects a large population of people.
I love it. So the last one is clearly trying to use that broader piece, but also you're looking for areas, and I hate to say we're fairly deficit driven, but some of it where you've not made progress on one of your issues that makes it a health problem because it's not making progress, or you have different goals or measures that you've not reached, or you compared yourself to other places. I would argue at the collection stage, you may want to just take every need as identified. You may want to try to collapse it, but keep it within your stakeholders framework, because you're going to have more needs and problems than you can take on. And so I'm going to talk about some processes you can use to trim it down that work well. But I do think having this discussion is going to be very important, and thank you for your examples.
And there's one question on that too, which you may get into, feel free to say that, but question, how do we interact with stakeholders without biasing their direction of the answer? For instance, asking about a health problem in general, rather than asking about safe sleep or infant mortality indicators.
That one can be tough because you really want to try to hear from the community and the stakeholders from their perspective. Usually what I've seen done is people provide out broad examples that give people the opportunity to frame it from their perspective. Now I get a lovely shot from Pat Ocampo, and that probably means she wants to say something. So Pat, please feel free to add.
Yeah, it's sort of a challenge that I wanted to bring up, and maybe some of the states have already dealt with this. It was mentioned that a problem that affects a large proportion of the community is something we should pay attention to. I think the problem of domestic violence, which affects 1 in 3 adult women in their lifetimes, yet we often don't have data on that, making it hard to establish baselines or benchmarks and monitor progress. Yet I think there could be more public resources going to that. That's my opinion. Working with the VAWs, the Violence Against Women sector, I'm just wondering how to handle those kinds of problems, Phil.
Good question, Pat, and you can probably give me the answer too, but I
I
tend
mean,
to say, that's why I
go,
like the
please do
broader
go.
definition of a problem. And I don't require people to have data at the identification stage. I
Okay,
prefer to have people bring up the issues they have, and then later we try to describe and capture those that we can. But
Mhm.
as Pat says, not everything that counts is currently counted.
Yeah.
So how do we measure that and address that? I would say that most decision-making process, Pat, that gets to be a challenge. But I mean, there is one approach that the students had a chance to do that don't depend as much on data, and another one does. So that may be what process you use to decide what's important. And I would also say that process may be really depending on your context of your needs assessment. What you do at a community level and how you do it at a community level or a neighborhood level may look very, very different than what you have to do at a large state level.
This is where academic researchers might be useful, because there are a number doing this kind of work across all states in the US. And so you might reach out to a local researcher who might be able to give you maybe not data for the whole state, but something to start with.
You definitely need to go, and we'll talk about some of the data sources in just a little bit, but yes. But I do want to start out with this idea of the health problem being broad. And I did not throw out that need to be data or measurable at this stage. Because many of the people who bring up the issues, especially community people, won't know the data sources. So our job is going to be to try and capture what it is and try to do that. But I love Pat's idea that if you don't have experience, this may be where you want to get help from others. But then after you've gone through this identification, again, you want to go to stakeholders, you may want to do surveys, you may want to do focus groups. People do public hearings or community meetings. People have available reports, evaluation data. I have seen now people trying to use the technology and internet and other pieces to try and collect pieces. But the idea is you need to be able to make sure that you're getting an inclusive perspective on what your priorities are based off your context and your resources. And you do need to do that compiling and pieces together. Then you come to what I call the next stage. Once you have your list, and you may try to do it along the way, but you want to describe what that problem is. As Pat says, if you don't have the data, that might be harder to piece. You can still at least describe it, but some of these other pieces are going to be harder. Can you begin to talk about what the extent of the problem is, the duration of the problem, what the expected future course, if that's known? What is the variation and disparities between population groups? What is the impact of that on the individual, on the neighborhood, on the community, on the state? And then you're definitely going to want to make sure as you do that problem definition for however you're planning to make your decision, that you collect the data that actually helps you feed that decision-making process. So this is where I say we try to define, we try to describe, and we try to validate as much as we can of the identified needs. And this is where the challenge can be. And frequently, sometimes where we have more data, it gets better description, and that can be a very challenge. But once you have this long list, how do you begin to decide where your priorities are? And there may be more than these, but these are about 4 of the processes that I and some of my other colleagues have seen. Some people use group consensus, some use voting, some use criteria-based rating, and some use Q-sort. And so I want to walk through some of this. Does someone want to share a good definition of what does it mean to work by consensus? Many people think of consensus as what I call a unanimous vote, that everybody agrees and selects the same issue. And that's really not what a consensus is. A consensus is when the group reaches the points that everybody can support a decision. By that, it may not be their first choice. It may not be what they would have voted for, but it essentially is something that the group is willing to commit to. The problem with consensus is if you have a larger group, which frequently your needs assessment does, it is very hard to get to a point of consensus. And frequently you've invited people to be part of your group who may work or focus in one area or another. And so that it is hard to get a common consensus when you do that.
Additionally, Bill, someone shared in the chat just that unfortunately, sometimes consensus means the bossy person in the room gets their way and quiet folks don't, which touches on your point as well.
Yeah, the loudest voices win, or the person with the most authority gets the decision. And so it really wasn't a group process.
Thanks for sharing, Kathy.
Thank you very much, guys. The other thing is people just say to vote. The voting is frequently done in the United States. Does voting build unanimous support? Hopefully we've just been through a recent election and you will say that that's probably not true. Voting is easy to do, but voting does not necessarily lead to cohesion and lead to common support. Voting, many people feel like they got voted off the island. And so that voting in and of itself has its challenges. But the next 2 pieces that I want to go in more detail that people are using is a criteria-based rating and decision process. And another is a Q-sort, which is a very unique but more powerful rating type of system. But I do want to come to this point. You need to handle the prioritization process well, because you need those stakeholders to buy in with you going forward to work on an issue. And how you make decisions and people's understanding of the process and inclusion in the process will affect where they end up at the end. So in the Q-sort, and you all have had some practice with this, the idea is you don't rank something from 1 to 10. 1, that's very hard. And then 2, it doesn't lead to as much discrimination. There has been mathematical work that shows that a Q-sort will actually lead to better discrimination of priorities than a simple ranking. The idea of a Q-sort is that you have people have 1 first choice, 2 second choices, 3 third choices. But not only are they choosing what is a priority, that Q-sort requires them to also prioritize what do we not need to focus in on. In MCH, this gets to be really important. And the reason I say that is MCHers, we never want to give up any issue. And we want to never say we're not going to work on something. The challenge gets to be is we don't have the resources and capacity to work on everything. In one of the states that I was at, we would have to prioritize things. And our scale got to be extremely high, very, very, very high, very high, high or moderate. We had no low priorities. And if you were moderate, you knew it wasn't going to take place. But we couldn't get ourselves to ever say something was low and we wouldn't do it. So what a Q-sort does is it does force you to choose what you consider as high and what you consider as low. Again, being low at the end of the needs assessment doesn't mean someone's not working on it. It means it's not your priorities. And it's not where your priority efforts go. But this process gets to be important. Now, I gave you 9 priorities. Just to be clear, I made it real simple on you because we had to have a minimum of 9 to make this work mathematically. So I eliminated down to the minimum number of problems. When I've done this with states, for example, when we identified problems in one of our needs assessments, we walked away with our first list of initial problems at 120 different issues. Well, you can't really fully investigate well 120 issues. So we found some preliminary information, but what we actually did there was we voted. We did that because there was literally so many, and we trimmed it down to about 28 issues. And from 28, we then tried to go down and eliminate it further. And we use these various processes to do that. So you just had 9, and you know what it takes to work on just understanding 9 issues from the exercise. Again, 42 of 49 of you did the exercise. So I gave you just 9, but you should have had 1 first choice, 2 second, 1 third, 2 fourth, and 1 fifth. Most of you got it right. One of you turned it in as a ranking of 1, 2, 3, 4, 5 for only 5 of the 9. So I had to knock you out of the exercise when we get to the exercise. But most of you understood what this was and did well. So that's how you do a Q-sort. And then you can do a ranking scoring, and you can get some idea of what the leading measures are. On the prioritizing side, what you do is you upfront say, what are your decision criteria? How do you want to, okay, you let the group of stakeholders decide how you identify something as a problem. Now you come back to that group and you say, okay, what is our criteria that we're going to use in advance to decide what our priorities are? That could be the severity of the problem. In other words, it has a large impact on the individual or the community. It could be how large the problem is. Is it very common among some, very common among all? How large is that problem? What is the trend? Is it getting better? It's continuing to get worse. We're not making any improvement. It could be that you already have state objective goals in your state health improvement plan, or you have national objectives, and you're going to, our agency priorities, and you're going to use that to help you decide. You might decide that you want to focus in on areas where you already have program capacity or initiative or work, and so you get points for that. You may want to put preventability based off of what we currently know. Do we know how to really solve this problem? For example, with maternal mortality, we know that over 90% of hemorrhage and hypertension deaths could be prevented by mortality review. That means that has a prevention component given what we currently know. You could do it based off of agency capacity. Can we deal with it? Can we not deal with it? It's in our scope of responsibility. It's not in our scope of responsibility. But you need to sit down with your group and decide what criteria you want to use. I've listed 7 here. I know these have been modified. People have done added, subtracted, reworded. For your example, I limited you down to 5 just because of the manpower and time it would take for you to do the exercise. do be careful. Some of us are epidemiologists and we think that everybody does truthfully with numbers. There's a criteria that I just shared with you, and then people play with numbers. And if you don't think they play with numbers when they give ratings and rankings, you're not wise in data collection. Because people have their personal preferences, they may have political agendas, they may have program priorities, they may have funding, it fits with the staff. So they may start fudging their criteria scoring, and you really can have some challenges trying to stop that. So let's walk through what we did in the example. So how does it work? So first, you have these criteria that you selected. You could choose to weight the criteria. In other words, you may say of those 5 to 7 criteria you selected, that some criteria are more important than others. And you can affect that by the weight that you assigned. You can also affect that by the scoring that you use. Either method would let you score something more or higher or lesser. On your scoring, I would suggest that you try to be specific as you can with how someone should score something. Your hope is that that would make for less fudging. But for example, with severity, you may want to say low, medium, high. With magnitude, we want to include minorities. So it's better without disparities, better with disparities. The idea is where do disparities fit in? And you can build that into your magnitude, or you can build it in as a criteria. I've tended to like to build it in with magnitude.
Bill, a question from the group again. How do you recommend dealing with those people who are fudging the numbers to meet political personal goals or are manipulating those numbers?
Let's be clear. In any of the prioritization processes that I suggested, consensus, Q sorting, voting, criteria-based, there's not any way you can stop somebody from how they choose to provide input. However, if you do have some of the scoring mechanisms here, you can make it clearer. And the hope is that you have enough people in your stakeholder group that it will balance out. And this is where if you have everybody contributing to a process equally, although someone may be the louder voice or carry more weight in the room, the hope is with the people in the room that will balance out. Because that issue you're talking about is going to be there. And let's be clear, even if you have it balanced out and that person's an authority, they still could do something differently in the end. But all you can do is be honest to the stakeholders in the group process. And my hope is that the decision-making process as it relates to the group is defined up front. So when the agency director was the one who would choose the final priorities, you need to tell the committee, we're going to give recommendations. Those recommendations that you give need to be approved by the program and by then the agency director, and they will give you feedback back off to what. And then they have to decide the political consequences of going against the recommendations. Your job is to make sure that everybody has the chance to voice their opinion. So even when certain people are louder, you need to make sure you do processes that gives everybody a chance to communicate. The biggest problem that I would say that I would worry about is less about someone fudging on the scoring and more about who leading the process, trying to lead the group in a specific direction. The integrity of the leader of the process can have a huge impact. And that's where we need to make sure that you have a balanced leadership in that process. Now, some people, depending on the needs assessment you're doing, may choose a common metric. You might, like the leading causes of death, you might say it's all mortality. You might say leading causes of hospitalization. You might try to say that those that cause potential years life lost, the ones that cost us more dollars. Some use population attributable risk. So, and it's really nice if you're doing a needs assessment on an issue that can fit in such a neat box. I will tell you, in my experience at MCH, most everything we look at doesn't fit into a common metric. So the process we need to use needs to be able to work with multiple metrics, especially if you're talking about something like Pat brought up, where there's not good data on, then you have to be very careful because it's hard to make sure that that gets fairly considered. So how does a weighting work? Again, 1 to 3 in your exercise. Most of them go 1 to 3 there in the exercise I gave you to keep it simple. Again, I would encourage you to keep your criteria simple because the more complicated you make it, the more work on your stakeholders and the lower your response rate and participation. With magnitude, with current program, it's either yes or no. And then we had magnitude. I use 1 to 6. You may have your own scores, but it's very important to say up front. But then what you basically do is you take your weighting, you take your scoring, and you multiply it out and you can come up with numbers. Now, I put weighting out there because there's always somebody who doesn't want to weight things the same. So it shows you how you can deal with a group process where they want to have more flexibility. I've been doing this with different groups for years, and almost everyone I know does not use weighting. But I do want to let you know weighting is an option if you run into that problem where people don't think things are equal. Again, it does add complexity. So what are some of the problems with prioritization? Number one, there's no real commitment to choosing priorities. In other words, the people you're leading who have to go through the process because the grantor requires you to do a needs assessment already have their priorities and they're not really interested in choosing new priorities. That's a problem. But the other problem you have is you're trying to obtain consensus support for the priorities selected. You won't get everybody, but you want to get as many of the relevant stakeholders you can. So you have two sides. You have those people who want to pre-wire it, and you have those people that you need to bring on board and make them feel engaged and committed. And you have both streams. Be very careful with an unclear decision-making process. If you burn a group and you're burning all your stakeholders, they're not going to stay with you, or not at least at the same level. Watch out for your special or hidden agendas. And if you try to manage them if you can, and we need to get into specifics on some of that. I would also tell you that most people in MCH cannot say no to anything. And so they select more priorities than they can do. Currently, I think you're allowed to have 7 to 10. And I finally got one of my Title V directors that I worked for to agree that we were going to go for 7. And the basis I said was, we're not working on all 10. We're not having an impact. Why are we putting ourselves before the feds, committing to 10 priorities when we cannot do them all? Why don't we limit it down to 7 and try to make sure we work and focus better on those 7? Designing an all-inclusive priorities. So if I can only have 7, Bill, what I'm going to do is I'm going to clump a whole bunch of priorities together and call it one priority. Well, the only person you're fooling is yourself. If the problem you're working on requires totally different work plans to address the issues, then it's more than one problem. A frequent area that I see people trying to do is they put access to healthcare as one priority. Well, in the women, children, infants, children, and families, there are a variety of different work plans that would need to be developed to work on access for those groups. And so I would argue that that is not one priority. And the last one is we have a tendency in MCH to want to choose a priority that's way beyond our capacity. For example, access to healthcare, especially for children and getting people on health insurance, it's clearly been a priority with SHIP and with expansion of Medicaid and everything else. But in many of the public health agencies I've been in, that is not their authority. And in fact, one agency I've been in, they were informed by the governor's office not to address that issue. So to hold yourself to a priority that you're not permitted to work with because it's not in your capacity is a setup. So do think through that as you start making your decision making. Again, it's very important that your needs assessment and what you select as priorities eventually can be looked at capacities. So this is where, and to the next steps, this is where we, again, talk about the systematic process to feed it. But remember, you need to think about the larger planning piece. For a group of stakeholders come up with the priorities and then not worry about it again for another 5 years does not get you anywhere. You need those people who are going to stay with you from the start of your needs assessment through the work plan to make that difference so that you can really work on the issues you choose. So do think about the who, the what, the whole process as you do the needs assessment, that your needs assessment fits into that piece. And I have not gone over part 2 and going into the health problem analysis and digging in to make sure you understand what's going on so that you can choose an effective plan and strategies. And that's going to be essential because if your next step in the planning process is capacity and strategies, you need to have that detailed information to be able to have that next step and process take well to lead to a plan. So I want to go into the different methods using your exercise, but at this point, before we go into some of the nuances, I want to see if there's any general questions about needs assessment and laying it out in that framework. Comments, questions?
Sorry, this is Nicole from Hawaii. I had a question with regards to when they say preventable with current knowledge. Is that just in terms of like if someone has the knowledge, like they'll breastfeed? Is that kind of what you're meaning when you say preventable with current knowledge?
But the way I would try to frame it is if you have a health problem like breastfeeding, and I look at the interventions that we're already doing in our community or at the state level, and I'm talking about what other new strategies I'm going to propose, then what level of effectiveness can we have within our community and state in terms of dropping it if we implemented those strategies? So it's not whether, for example, I did bring up the example of prevention of hemorrhage deaths for pregnant women. It's not about, we did the interventional reviews of maternal mortality, and we can say if all of them got the current best practices, we could prevent 90% of those deaths. However, that's not a strategy. So the next thing is, okay, if that's the issue, how likely, if I do a quality improvement initiative, can I change those behaviors such that those deaths, and what percentage of those deaths would be prevented if I did that strategy? Does that make sense?
Yes, thank you.
The idea, because some problems we know really what to do and our interventions are very effective, and some problems they're moderately effective, and some problems they're somewhat effective. And so the idea is if you have a large problem that you cannot address, is a program implementation where you should be focusing.
Thank you.
Other questions? Okay. So let's talk about your example, because I think it will provide some interesting illustrations. Again, you all gave the 9 health problems. You had descriptions based off of, that we provided. They come from the Florida Department of Health. Thank you, Florida, for doing that, so I didn't have to create fictitious ones to do that with. But the idea was it would provide you enough information that you could prioritize. Again, we're trying to think about it. The whole idea here is we're trying to obtain from stakeholders and leadership an agreement and commitment to selected priorities, and have stakeholders and leadership believe they contribute to those, develop leadership support for selected priorities, and motivate leaders to move forward. So this, again, I just want to make sure that we realize we're trying to get this group into action, and that, believe it or not, our needs assessment needs to lead into action, because I've been doing needs assessments since Title V required them. And I will tell you, there were many states who, after the end of the needs assessment, were still not clear what they should do. They knew a lot about their problem, but it did not lead them into clear directions or thoughts. And they just chose. So you have your 9 problems that you read through. Am I going the wrong way? So you did your Q sort. When you did this is what your answers were. With a Q sort, the lower the number, the higher the priority. This is where your 9 fell out. Inadequate child health insurance coverage was number 1. Risk appropriate perinatal care was 2. Developmental screening was 3. Infant sleep practices was 4. The key things is adolescent physical activity, and youth household secondhand smoke was last. And Pat, I should have had domestic violence here. That wasn't an option given to me from the Florida Department of Health. So I tried to get some different ones. Now the key gets to be is it's not just the vote. And this doesn't mean this selects our highest priority. The way I like to use these prioritization tools is this is a starting point for discussion among the stakeholders where our priorities are. Why do I say that? Because can someone tell me the relative difference when the mean is 2.59 from 2.61? Are those really different? I mean, how different does the score have to be for the priority of those issues to be different? The second thing is you want to be inclusive, and you want to make sure that as you do this, that you have all the information, but more importantly, all your stakeholders have had an opportunity to think about it, to respond, and make sure that everything is there. The key is you guys were homogeneous. I've done this quite a few times. You're the first group who relatively use Q-sort to rank things similarly. Our last group was bipolar. Why do I bring that up? It's not only important that you look at the mean, it's important that you look at the distribution where people rank. Because last year, they had a fairly large group who wanted it as a priority, and they had a fairly little group who said it really wasn't a priority. Why would that be important for you to know if you're leading the decision-making process? I can't show that here with your data because you all didn't do that, but last year's group did. Why would it be important to understand that you had a U-shaped curve?
A
One
comment.
thing you may want to do is, do the people, you got something in the box?
Yep, a comment came through. Difficult to have buy-in if half of the participants have opposite opinions about priority.
Absolutely. The second thing is, those who prioritize it may have information that you didn't send that everybody needs to know. In other words, you may want to understand why some thought it was high and one thought it was low. And you might have added information that you would not otherwise have. So it's going to be important, one, that everybody be heard and have some understanding, and make sure that there's not information that people need to know that might change their decision. The other thing I would tell you, if you start with this, is I usually go through a process where we try to walk through this. And what I mean by using this as a starting point is we take these results, we present them to the stakeholders, and the first thing I would say is, okay, this is where things ranked out. Do any of you believe that any of these are ranked too lowly? And why do you think they're ranked too low? This gives an opportunity for people to say, I think this is too low because of X, Y, and Z. So it gives them a chance to be heard, and hopefully everyone will be open to listening. And then if people voted for it lower, they would then have a chance to respond why they considered it lower, so that everybody is at least working from the same information and knowledge set. And then, believe it or not, in our process, we've elevated some based off of the new information, and the group was supportive in doing so. Then we'd say, well, are some of these too high that shouldn't be? In one of the states I was in, adequate child health insurance was rated number 2, not number 1, but number 2. And I had to remind the group that the governor has said our agency cannot work on this issue, that this is to be addressed by another agency and they should only be dealing with this issue. And given that our agency director reported to the governor, it probably would make sense that we follow his direction. So we had to bump it down. Now, it did not mean that it wasn't a priority in our state. It just means as we get ready to make our plans for the next 5 years, that is not going to be approved as a priority. Does that make sense? Or so you may say you don't have the capacity to do that. Or you may say that there's some other reason that we can't do that. So we would raise some priorities and we would lower priorities based off the discussion. Again, the hope is that we'd have more information. It would lead to better buy-in, and people didn't consider it a mathematical game, but as a group process and understanding the situation and our priorities. Does that make sense?
There is a question. If
Uh-huh.
agency isn't able to work on an issue, would it be allowable to not include it in the survey? Maybe just acknowledge that it is an issue.
This depends on your process and how you decide to do that. I would argue that if this is a group decision-making process, if the group decides not to include it of stakeholders, that's okay. But I think if you have stakeholders that you're wanting to work with, see this as a priority, yes, you cannot work on it. You still may need to give people the opportunity to talk and share about it. So you can try to knock that out in the process where the group thinks it's okay. I would encourage you to be careful knocking it out on your own, because what does that make people think of a group process when you as an individual can knock it out on your own? If people feel like you're playing with or jerry-rigging the process of decision-making, you're going to lose credibility and you may lose buy-in. I hope that answers the question.
Yes, she said thank you.
Other questions, comments?
Another comment from a little bit earlier in the conversation, perhaps, but Avatola shared, I would recheck the composition of stakeholders and ask the question, do I have an adequate representation for that particular priority?
Ooh, that's a hard question. Do you change your stakeholder group based off of priority? Or what you could say is you see something and you think it's too low, you could then have a process where people work with those other people on that issue to make sure you have the most up-to-date and correct information. Again, if you choose your stakeholders based off the issues you're selecting, are you having a broad-based decision, or are you stacking the committee? So I definitely agree that if you have, my hope is that you have inclusive people from the start. This is where when you start your committee, I hope, and we didn't start there, when you have your committee, I hope that you start on the inclusive process of who you need from the start. And if you don't have an inclusive stakeholder group, then you're going to get the result that you do. Now, that inclusiveness depends on the scope of your needs assessment and your project. With some of our needs assessment, we've had a larger, more inclusive group. When we had constrained resources, we had a narrower group. We did not want to bring in a bunch of partners who get all excited about working on new issues. That was not going to be able to happen. So you needed to find that. But the best time to be inclusive in your group is not at the decision-making point, but would be earlier in the decision-making process. And if you're missing someone later, I would encourage you to get information from them, but not necessarily put them into the committee. Other questions, comments? Okay, so now I'm going to put this down because what did you learn? What did you think about QSOR? Kathy, did you want to say? Kathy, do you want to say something?
So I was going to say, I think it caused me to think a little bit more critically about each of the issues instead of just going with like my gut. I'm going to rank it based on what I think is important. So when you're talking about having, more perspective and really thinking about like, is this something that we have capacity for, agency for? I think it really stopped me to think about those things rather than just like, this is important, it should be a priority.
It definitely makes you think about it, especially think about it in relation to other issues. And it sort of commits you to do that. Did you have problems, Kathy, deciding what was lowest?
A little bit, yeah. I think it like I said, I really had to stop and think a lot more than just saying like 1, 2, 3, 4, 5. And based on what I was ranking other things, I kind of went back and like, oh, I ranked this one higher before. Did I want to, now that I'm thinking about the other one? So, yeah.
There were a lot of comments. Ashley, do you want to share some of them?
Yes, I can go ahead and start. Maria shared she liked it because it forces a decision. Jessica, I like it better than just ranking from 1 to 10. Eva, I think it is very interesting and would be interested in trying it out. And Becky agreed. It helped me think about what or how I was prioritizing instead of going with my initial gut feeling, as Katie said. And Maria I found a lot of times I work with stakeholders with prioritizing. They will say everything is a priority, as you mentioned earlier, Bill. Abby shared, I liked that it was a way to measure our perspectives of preventability, priorities, and et cetera, that end up coming up in these planning conversations anyway. Kui, I think it is easier to think about groups of relative priorities than trying to rank individually. Sudhir, issue-specific rating, which drives to a reasonable ranking.
We'll talk about ratings in a little bit, so let's hold off on that one.
Okay. And then Kathy shared, I really liked the exercise, though the degree to which the individual write-ups were well done or not really influenced my ability to rank.
Absolutely.
Mhm.
Now, the question gets to be, is you can provide the write-up, but do people need the write-up to do the Q sort?
Mm.
The answer is no. Remember, they can use it to the extent that they choose. But when you get it back from your method, however you do it, they're just going to tell you their answers. So although you can have informed decision-making because you gave it to it, how the information is used, how it is processed, how it is decided is left up to the individual. And we'll talk about that.
And Kathy shared a little bit more on that. Not everyone is an expert in all fields. I think it is important to give people info that might be outside their usual scope of interest.
You didn't hear me say I wouldn't give them the info. Oh, I would definitely give them the info. They need that to understand the problem. And you may actually need to have some discussion. That's why that discussion, even after prioritization, is important, because why made you make it high that I didn't? So I would agree the information's there. I'm just trying to tell you the process doesn't make you look at the information. And nothing actually does, but this one is pretty open. So now let's talk about the priority. Okay, so I gave you 5. Boy, you took a lot of time trying to have to rate each of the 5 components and figure it out. And it does make you go back to those data sheets quite a bit just to try and make sure you have it down correctly. Most of you actually did this one correctly, which is great. You're the first group that did. You all are very much an analytic group. Again, we have the weighting that you can use. We didn't use weighting. This is where you came up. Now, the higher the score, the higher the priority. Does anyone notice anything unusual about this? Does this look like the last ranking you just saw?
No, adolescent physical activity is ranked highest, where it was ranked lowest in the Q sort.
We're going to come back to that. But yes, it's very important that this is a different list of priorities. We're going to talk about the combination of both in a second. But it is different. Now, is there a difference between 15.6 and 15.5 on this scoring system? I would say no. So then again, this is where your new list is. This is where you start to discuss through it. And you talk. And you try to figure out whether something's too high, whether something's too low. Again, that vetting, the vetting is almost important as the decision process as the scoring is. The scoring just makes it so that you don't start out at all 9 equally out of the gate. If you think about it, this is where you're down to the last stretch, and now we're talking to make sure are people placed where they are in the process. Now here you don't look at all the data because it's just too much. So what I recommend people do is they look at the interquartile range. What is this interquartile range helping us in terms of understanding some of these priorities? What is it helping us understand?
How close the rankings are?
Yeah, it makes you know whether people really uniformly rated it similarly or whether there's a wide dispersion on how people rated it. Okay? So if it scores out high on our list previously, such as physical activity of adolescents, and it has a low interquartile range, it means it was high and there's a lot of uniformity towards that high decision. What does it mean about risk-appropriate perinatal care and low-risk cesarean delivery, though? It means we have disagreement in the group on scoring. Here, guys, we have objective scores. We had clear criteria and the 25th and the 75th percentile have a difference of a score of 4 between them. This is where you want to have discussion. So why do you consider risk appropriate perinatal care being scored higher and I didn't? What made it go so much higher? Does that make sense? The idea here is you want to again know, where is there a difference of opinion? Why do we have a difference of opinion? Could that difference of opinion and knowledge be what's driving a difference in a very score-driven decision-making process? Okay? So with both methods, I'm encouraging you to understand where the group as a whole did in a decision so that you can figure out where there's generally an agreement. In other words, not just about high score. High score with agreement is better than a high score and a lot of disagreement. So what did you think? Don't compare them yet. We'll come back because I've got some interesting findings for you. And you've already given a clue on some of it. But what did you think? What did you learn from the criteria process? Did you like it? What did you like about it? What did you not like about it? Yvonne, what did you think?
I thought it took out some of the personal bias from.
It got rid of some of the personal bias or preferences?
Yes.
It makes people be more explicit in how they're choosing.
Yeah, there's a sense of objectiveness to it.
Yeah, and I
like how you
would,
could break out the scores by different criteria. Yes, you could actually study the criteria if you wanted to. And it would let you compare criteria across, not just ranking, but you can now compare criteria across health problems so that you felt more comfortable with how you were scoring your criteria. Any other feedback? Did it take you a lot of time? Was it a lot of work?
I think it took more time than I would have, like you said, if I just ranked them without critically thinking everything, which I like about it, because then there's the people who are just impulsively ranking stuff that have to be able to justify why they're ranking things the way they are.
Anyone else?
Others are agreeing in the chat. Yes, more time intensive, which required more thinking about the decision making.
A lot of people don't like it. In fact, you did with this group, but with some of my groups, some of the people didn't even finish the exercise. Either it took too long or they didn't like it so much they didn't want to finish it. So now, this is a difference between the two decision processes. Now think about it. We have the same people giving the same data to review in detail. And I will say, as agreeable as you were with each of the processes compared to other groups, this is the widest disagreement between the two methods that I've seen. So what does this mean? Which one's correct? Which one's right? Which one do you use? Do you use either of them?
Can you use a combination? Was asked.
Well, that's always the question. But you can try to use a combination. Many of us have. For example, we've had some of us use Q-sort to go from the 20-something down to a more manageable number and then use the criteria scoring for the last segments. So in other words, most of us start out with too many problems in MCH, and we need to trim it down smaller and smaller and smaller. So we voted, you could do a different steps to try and get it down that take less effort from your stakeholders, but make you sure you have your better piece there. The challenge gets to be are any of these science? These are arts of decision making. We're basically trying to create a framework and a process to get people to agree on where our priorities are together. Is this a data-driven process? The answer is no. This is a value-driven process. So this is where you need to have upfront with your stakeholders what works and what doesn't work. Now, I want to give you some feedback, and we're going to come back to that discussion. I want to give you some feedback what Florida had. Florida distributed this to 40, they did the criteria base. They distributed to 43 stakeholders. They got responses of all the identified problems from 404. They came up with 19 options. They got, in terms of scoring, and they did the criteria scoring, they only had a 26% response rate. Most people were unwilling to take the time and effort, or could take the time and effort to do it. And they got down to 7. It is a hard process. This was what happened in Florida when they did some of the different processes. And they got some different answers because they did both of them. So this is where we had to have a lot of discussion. So let's first just start out, why are they so different? Why do we get different answers with different methods? Well, because they're go ahead, Caddy.
Oh, I don't know if I have a great answer. I just think they're kind of two different ways of looking at an issue or how to rank them. So that's probably why we end up with different answers. I know I did when on my personal one too.
Well, it probably means you're adding factors in the Q sort that you're not putting in your criteria. Some of those factors could actually be good and important things that should be included. Some maybe not as important. The other challenge gets to be is Q-sort gives you more freedom to put in your preferences. However, many people feel constrained by the criteria one. They feel very constrained that they're now being forced into a box to make a certain decision in a certain framework, and they feel like it doesn't include everything that they value. That doesn't mean they're wrong. That's why I'm saying it's a value judgment. This is where I think you need to know your group. Now, as epidemiologists, which of these methods do you think the epi people are going to really like? Q-sort or criteria-based decision making? Well, they're coming in, yes.
There's a
EPIs are detailed, number, data-driven people. And how many people like EPIs? I say that is that non-EPIs are not always so rationally driven or criteria number driven. They have more of a context. When I was at City Match, the director at that time didn't like criteria because she didn't want to be held within the lines. She felt constrained. That is not how she likes to make decisions. And she felt like it was artificial. And I was the epidemiologist, and I just felt like we were voting from the heart with a Q sort and not really getting down to those aspects of the problem that really mattered. And we are both right. When we choose priorities, we are as a group choosing values, those things that we choose to work on that have meaning to us. So this is where I want to emphasize that discussion about your ranking, whichever you choose to use, helps you. I do think you need to know your group. I can tell you, I've sat in certain groups and I can tell you based off how the group discusses and works and wants to make decisions, they want Q-sort because that's how they make their decisions. I've been in other groups where they need to have it clearly laid out. The details need to be there. We need to know why we're making that decision, and they need that. You can do both, but as you know, with the Department of Health, what was the response rate in the end? So this is where you got to figure out how to help the group to make a decision. I will tell you, if you use consensus, you use voting, you use Q-sort, or you use criteria-based, you will come out with some different orders. The key gets to be is making sure that everybody is sharing why they're making decisions in the process you decided, and what is the information, what is the rationale, and that you're building towards a consensus to work on the issue. And I would say with some of the larger MCH groups we've had, without using a Q-sort or a criteria-based scoring, we would not have gotten to a conclusion very quickly, because people would want to talk about their issues on and on and on, and they'd have no way to make that decision. And if we came down to voting, people would have been offended. By using the ranking process, you have the ability to have, okay, this is where we're starting, what's too high, what's too low, what needs to change. All right, let's see if I can go back to sharing screen. So a key is, how do you use the results? Okay, I thought I was at the end. Sorry, I just needed to confirm. I didn't remember. The key is, how do you use results? Again, try to think about it. You're trying to be visionary. You're trying to prioritize what everyone you want together to work together. You want people to feel included. You want people like they felt like they had a chance to share, that they can support the decision-making process. It was a visible, credible process that everyone can see value in, even if their issue is not chosen, and it leads you to priorities. I want to make sure you get away with that. And you may want to use these in different ways, but I do want you to know that there is no clear magic answer, and that it's a value process. The other thing is, I want to also remind you, as I told you, we have so many priorities in MCH, and I've been doing this so long, I can get behind almost any of them. My biggest frustration is when we don't choose what our priorities are and choose a few priorities and make an impact. When we try to do too much, we try to be too broad with too free resources, I always worry that we're squandering our effort and we're not doing the best for what women, children, and families need. And so we need to figure out how to collectively together can we choose those priorities so we can make those differences. And I am an epidemiologist, and I tend to lean a little bit more heavily towards criteria-based decision-making, but I tend to try and do that with a smaller group, or not too small, but I try to do that with a manageable group who's committed to trying to complete it. Comments, questions? Was this helpful? I guess we'll see the evaluation questions. I don't currently have a classroom time for you all to come talk. Please send me an email. I'm happy to meet and talk with you anytime at any place. For some of you, you may not want to have this talk until you're ready to work on a needs assessment. And I'm happy to have your talk then. I'm happy to have it now. I will meet at your discretion. My experience is that a group discussion usually doesn't work as well as individuals. So please don't hesitate. I'd like to help you. And if you also want to talk about what can you do and how you do your work within your agency to be more effective, let me know, because I've made all the mistakes and I can tell you about them. And I'm a results-driven person, and I want to figure out what I need to do to make sure that we can make a difference. With that, I'm going to turn it over to Ashley and Mike. If Mike's still with us.
I think so. Yes, there he is.
I'm here. Yeah. And I'll just reiterate something if I can, Bill, that that in trying to build consensus with especially a big group of diverse stakeholders, which you often have in a needs assessment, the process is really important, and getting buy-in for your process up front is really important. So saying, at an early meeting, saying, okay, the process that I'm proposing is that we're going to start with this big set of, if I can get my hands in the right place, big set of potential priorities, and then we're going to use a Q sort. And this is what that looks like. And from the Q sort, we're going to cut it down to this more manageable set of priorities. And then we're going to do this criteria-based rating. And these are the criteria that we're going to use. And then we're going to use that process to get down to our final set of priorities. Do you agree to support the results that come out of this process? Right. And if you can get everybody to buy into your process and agree to support that process, then it makes the decision making for your needs assessment, and it makes the conversations that come through your needs assessment much easier to have, right? Because you can always anchor back to that process that everybody agreed on, and say, I'm not doing my job as the facilitator if I'm not working this process that we agreed on.
The only thing I'd add to what Mike said was, it's good to have a decide on each of those decisions separately. Can we use Q sort for this? And if you have the freedom to say, and what criteria do we use? Are these criteria okay? Do we need to change them? And please, 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 if this group is only making recommendations to leadership, please tell them that up front, and that leadership has agreed that they will communicate back with you if for some reason those recommendations have to change.
And follow-up is really important there
And
on the
they
back
stay
end.
Engaged. Sorry, Michael, I didn't mean to.
No, that's great. Yeah, I was just saying that follow-up on the back end is really important after the process, so that the committee doesn't feel like they were just used to come up with these decisions, and they don't have any, any impact in partnership and anything beyond that. Yeah, following up with any decisions that are made and following up with what the action steps are is really important.
There's nothing worse for a partner to help you go through this long decision-making process and then never to hear from you again about the issues that you decide you needed to work on. The whole idea of the stakeholder process is that they're going to stay with you to work on the issue. And believe it or not, I have seen that happen. And you talk about burn off a lot of your partners quite quickly. You have done it. In other words, are you in this together? Are you not in this together? Are we going to play by a common set of rules? Or are you just going to go off and do what you wanted to do?
And then, at least in the Title V framework, you try to go back to them again 5 years later, and they tell you to go jump in the lake.
Absolutely. Thank you, Michael. Any other comments, feedback, questions?
In the chat, use a listserv to update our stakeholders during the in-between times.
Very much so. And then I'm an old-fashioned Southerner. Warm personal touches occasionally are very powerful. I'll say that again. Warm personal touches to people are very powerful, especially if you have people who are not being engaged. Someone caring enough to reach out to get their opinion and get their inclusion is worth the gain. Because I promise you, you'll be going back to them for something else.
Yep, and another comment, I agree with what you've been saying at the end here. Most of our stakeholders are the programs we contract to provide services, so we really can't afford to burn them in this process.
All right. Well, I wish you guys a fabulous weekend. Again, if you have questions or things, let me know. I'd be happy to be helpful. And best wishes with what you do. Again, I think what you do is some of the most important work an epidemiologist can do.